Please start, ma'am. We are live now.
Okay. So, good afternoon, everyone. I'm Dr. Divya Gupta, Periodontics Guru at DBMCI MDS Experts. And I hope you all had a great INICET. So, now is the time to sit back, relax for some days and analyze yourself. Analyze how the paper was, how was your performance, which topics, which questions you were able to recall, which questions, which topics were like very new and you did not had time to read those topics. Okay, so you have to sit back and analyze. And also one more important thing is that it is a long journey. If you think you have not performed that good during INICET May 2023, don't worry. You have more exams, more INICET, November is there, NEET exam is there. In that, you can always score, you can always perform really well. But the important thing is to analyze. Just analyze where you went wrong, okay? So I'm really proud to say that DBMCI we were the first one to bring to you the complete analysis of INI May 2023. And since last 3 days, we are discussing all the recall questions and the answers along with explanations to those questions. So I'm here to discuss to take the recall session on periodontics. So let us get started. See, in periodontics, there were total 19 questions and approximately 10% of the questions were from perio. And in that, I will say that perio was like most of the questions were repeat, and also some questions were directly picked from some MCQ books. Some questions were from our INICET mock test, which we gave in our DBMCI MDS Experts group. From that also some questions were there, some repeat topics were there from that same paper. So while we are discussing, I'll tell you which questions were there, which topics are repeated, which questions are repeated. Only I think two to three questions were a little bit tricky, but they were also from the topics which are most commonly asked. Okay, so if you have done like a detailed study on a topic, you will be able to answer the questions easily. The paper was not at all specifically talking about the periodontics paper. The periodontics questions were not difficult. They were like easy to medium questions. Okay, so let us get started. The first question is, it was a statement and two statements were made, and it was asked which means whether both the statements were correct or not. So the statement one is, there is an assumption that management of gingival health in a pregnant female has impact on the adverse pregnancy outcomes. So this adverse pregnancy outcomes. So what are the adverse pregnancy outcomes? First, we have to know that. So adverse pregnancy outcomes are preterm deliveries and premature rupture of membranes. So what happens is in preterm deliveries, there is the pregnant patient gives birth before 28 weeks. So a normal term of a pregnant patient is 40 weeks, right? But if the delivery is done in less than 28 weeks, so it is called as preterm delivery, and the child which are usually born, they are known as low birth weight babies. So the weight of the baby in these preterm deliveries is usually less than 2,500 grams. Okay, so why this in these adverse pregnancy outcomes, what is there, what happens? It was seen in certain studies that preterm patients are most commonly affected by bacterial vaginosis or urinary tract infections. So in urinary tract infection, what happens is the normal lactobacilli, which is the normal habitat of urinary tract, it is replaced by the anaerobic bacteria. And these anaerobic bacteria are Porphyromonas, bacteroids, Prevotella. These all organisms are there. So what they do is, whenever there is UTI, these organisms colonize, means their population increases and the lactobacilli decreases. So they produce endotoxins. These endotoxins cause injury to the endocervix and the vaginal tissues. Because of the injury, now what happens is there is increase in the inflammation. So there is increase in the inflammatory mediators. So one such inflammatory mediator is prostaglandin E2. Okay. So in pregnancy, it is noted that prostaglandin E2, a certain amount, a threshold of prostaglandin E2 is required to produce uterine contraction, and this threshold level is reached in about 9 months. Okay. Now, because of this infection, UTI, this urinary tract infection, what happens is prostaglandin, the amount of prostaglandins, the amount of cytokines increases. Okay. It increases. And because of this increase, what happens is the threshold level of prostaglandin E2 is reached at an earlier time, means before 9 months. Thus, it causes uterine contraction, early uterine contraction and rupture of the membranes, which leads to preterm delivery. Okay. So this is the urinary tract infection we talked about. Now, there were certain studies done, as we all know, that the dental plaque composition is also similar to the composition of the urinary tract infection bacterial microorganisms, which we talked about. Means in the subgingival plaque also, there is increased amount of anaerobic organisms like Porphyromonas, Actinomyces, Prevotella, species. All these species are there, okay, which are found. These species are similar to those found into the urinary tract infections. So what happens is, there are the effect in periodontal disease. What happens is, in periodontal disease, what happens? There are two pathways. There are direct pathways and indirect pathways. So in direct pathway, what happens is the bacteria that is present into the subgingival plaque, the harmful pathogen which is there into the periodontal tissues, which is causing the degradation of the periodontal tissue, will spread directly to the fetoplacental unit through hematogenous route. So it is a hematogenous spread of microorganisms. Okay. And in indirect periodontal disease, what happens is the toxins which are produced by the bacteria, the toxins as well as the inflammatory mediators which are produced from the damaged tissues, which are prostaglandin E2, cytokines, and the toxins, they reach the fetoplacental unit, and there they cause premature uterine contraction, or they cause the rupture of the fetoplacental unit. Okay. Or they can directly go to the fetoplacental unit, or they can reach the liver, and there in the liver, what they can do is they can induce the liver to produce pro-inflammatory cytokines, which in turn causes uterine contraction. So this is the mechanism. So we can say that, so the statement one, that there is an assumption that management of gingival health in a pregnant female has an impact on adverse pregnancy outcomes. So we know that gingival health has an effect on pregnancy outcomes. So the second point is, if this is proved, it can be considerable. It can be of considerable help in aversion of adverse pregnancy outcomes, as these factors are preventable. So what was seen was that there were various studies done And one study was done by Jeffcoat and colleagues. They proved that preterm means periodontitis pregnant patients, when they were given prophylaxis, means in the patients in which there was scaling and root planing done, and when they were followed up in the, and this scaling and root planing was done in the second and third trimester. So when the pregnant periodontitis female patients were given oral prophylaxis, there was 1.8% chances of having preterm deliveries. Now, periodontitis patients who were not given oral prophylaxis, in whom this scaling and root planing was not done, in those patients, there was 10.8% chances of having preterm deliveries. So it proves that if we do scaling and root planning during the second and third trimester in pregnant patients, they have favorable outcomes. And till date, there are no studies which have proved that doing scaling and root planning in pregnant patients is harmful in any way. So we can say that this statement, if scaling and root planning is done, then adverse pregnancy outcomes can be prevented. Okay. So according to my explanation, we can say that option C, which is both the statements are correct. This is the answer to the first question. Okay. This was a little bit tricky question, and if you have studied pregnancy and periodontal diseases in detail, this question you will be able to answer very nicely. Okay, so let us go to the second question. So the second question is, all these conditions will cause gingivitis induced by local irritating factors except. So gingivitis is the inflammation of the gingiva, and it is plaque induced as well as non-plaque induced. Okay, so gingivitis is plaque induced and non-plaque induced. Now, recently in 2017, the World Workshop gave a new classification, a modified classification of periodontal diseases, in which these two subgroups were given. It is like a very big article, very big classification. But here I have given these two, I'll show you these two different classes. And in those you can, if you know the classification, you will know that which are plaque-induced gingivitis, which is plaque-induced, means for the diseases, for the systemic conditions to cause gingivitis, it is necessary for the that plaque should be present. Means the diseases or the conditions by themselves cannot cause gingivitis, but there are certain conditions, certain diseases in which gingivitis can occur even in the absence of plaque. Okay, so here in this, the plaque is the primary factor, and in this, the plaque is not the primary factors that is required for gingivitis to occur. Okay, so let us see first the classification and then we'll discuss the options. So this is the classification of non-plaque induced gingival diseases and conditions. This is a very big, I'll just read the main headings. You can pause the video and have a look at it. The first is the genetic and developmental disorders. The second in this is specific infections like the bacterial infections, viral infections, fungal infections. Okay. Then there are certain inflammatory and immune conditions and lesions which can cause gingivitis in the absence of plaque. And they are like hypersensitivity reactions to something, autoimmune skin diseases like pemphigus vulgaris, lichen planus, granulomatous inflammatory conditions, reactive processes like epulis formation, pyogenic granuloma. Okay. There are certain pre-malignant conditions like erythroplakia, leukoplakia, which can result in gingivitis, gingival diseases in the absence of plaque. Malignant conditions like squamous cell carcinoma, leukemia, lymphoma, endocrinal, nutritional, and metabolic diseases, traumatic lesions. Okay, just remember this traumatic lesion, because there is another question in which you will need to know that why they have given that question this time. Okay. So traumatic lesions were included recently in this 2017 classifications. Only they have included this traumatic lesions. So the traumatic lesions are of physical or mechanical insults like frictional keratosis, toothbrushing, induced gingival ulceration, and fictitious injury. Chemical insults are itching, chlorhexidine because of itching, chlorhexidine, acetyl salicylic acid, cocaine, hydrogen peroxide, dentifrice agent, detergents, thermal injury like burns of the mucosa. Okay. Then gingival pigmentation, melanoplakia, smokers, melanosis, amalgam tattoo, all these are gingival conditions in which plaque, these are non-plaque induced. Now, gingival diseases because caused by the dental plaque, and they are gingivitis associated with the biofilm alone, gingivitis that is mediated by systemic and local risk factors. Now, the systemic or modifying risk factors are smoking, sex steroid hormones, like in pregnancy, puberty, menstruation, menopause. Okay. Oral contraceptives, hyperglycemia, as in diabetes mellitus. Nutritional factors are there. There are certain vitamins deficiency, vitamin A, vitamin B complex, which can cause gingivitis in the presence of plaque. Pharmacological agents and hematologic conditions. Hematologic conditions like leukemia, agranulocytosis. All these conditions can cause gingivitis in the presence of plaque. Okay. Second is local risk factors, which are predisposing factors like plaque and oral dryness. And the third is drug-influenced gingival enlargement, which causes gingivitis. Okay. So now let us go to the options and the questions. All these conditions will cause gingivitis induced by local irritating factors except. See so the options given are: A is agranulocytosis. Agranulocytosis is a hematologic condition which causes gingivitis in the presence of plaque. Atherosclerosis is a heart disease, heart condition which causes gingivitis. Tuberculosis is caused by Mycobacterium tuberculosis. Okay. And it is of bacterial origin. It causes gingival diseases in the absence of plaque. We have already seen in the classification. You can just go through the classification once again. And diabetes. Diabetes also causes gingivitis in the presence of plaque. So the answer of this question is C. Okay. This classification is very important, and I have discussed this classification in my recorded session. I will be discussing it in my live sessions too. In detail, I'll discuss this classification because nowadays various questions are being asked from this classification as well, and it is important for the final year students as well. Okay. So now the third question is, all of these can be used as plaque disclosing agents, except. So what is a plaque disclosing agent? Plaque disclosing agents are certain staining agents which stain the plaque, which stain the calculus, debris, materia alba that are present onto the tooth surfaces. They'll not stain the normal tooth structures. And thus we can, they can help us to identify where all the plaque is present, so that we can properly do scaling and root planing. They can also be used as a motivational tool for the patient to maintain the oral hygiene. They can be used for follow-up. In the cases of follow-up, we can educate the patient whether they are able to maintain the oral hygiene or not. Right? They are also used in various studies where we have to do longitudinal or cross-sectional studies or randomized control trials. Disclosing agents are used. So there are various kinds of disclosing agents. So the see, this is how a disclosing agent will stain the plaque. In this picture, you can see this pink. This is the erythricine dye, which is used to stain the dental plaque. So what we do is, it comes in a form of solution or a vapor. We ask if we are taking a solution, we'll ask the patient to take a small amount and swish it in the mouth and spit it out. Okay. When the patient spits it out, it stains the plaque and it does not stain the tooth. Here you can see, wherever there is no plaque, it will not stain that part. It will stain only the plaque area, not the non-plaque area. Okay. So this way we can easily identify where there are heavy deposits, and also we can motivate and educate the patient that this is the condition of your oral cavity. This is the condition of your tooth. Okay. So, and in wafers, wafer form of disclosing agent, we'll ask the patient to chew the wafers and spit it out, and it will stain the plaque. The various preparations of disclosing agents are iodine preparations. In iodine preparation, it is Skinner's iodine solution and diluted tincture of iodine. Mercurochrome preparations, mercurochrome solution 5 favored mercurochrome disclosing agents, Bismarck brown, merbromin, basic fusion erythrocin, which is known as FDC red 3, FDC green, FDC yellow 8, and two-tone solutions. So these are some of the disclosing agents. Okay, let us go back to the question and the options. So the options given are, number 1 is erythrocin. We have already seen that erythrocin is a plaque disclosing agent. Second is mercurochrome, which is also a plaque disclosing agent. Cetylpyridium chloride. Cetylpyridium chloride is a mouthwash which is given to the patient, and two-tone solution is also a disclosing agent. So cetylpyridium is a mouthwash. Thus, this is the answer. All of these are the plaque disclosing agent except cetylpyridium chloride, which is the answer. Now let us go to the fourth question. The fourth question is, in case of gingival trauma, which of these is advised? In case of gingival trauma, which of these is advised? The first is aggressive debridement. So this picture was not given, okay? This picture was not given. This I have just kept it so that I can explain it to you. This picture was not given in the exam. In the exam only this question was given. In case of gingival trauma, which of these is advised? So option A is aggressive debridement, as it will heal due to the blood supply, good blood supply. So they have asked this question because gingival trauma, as you have seen, as I showed it to you earlier, that it is included in the recent classification of periodontal diseases. So gingival trauma can be, as we have already seen, it can be because of physical trauma, mechanical trauma, physical and mechanical trauma, like iatrogenic induced, because of some bird is getting their injuries to the cheek, to the gingiva because of the burr, because of some instrument, because of scalpel, okay? Cotton is kept, and when we remove it, there might, and petroleum jelly is not applied, it might cause frictional injury to the gums. These are physical injuries, okay? Now the second type, or fictitious injury, like the self-inflicting injuries the patient is doing because of certain habits, which are very difficult to control in a patient. Now, the second type is chemical injuries. Chemical injuries because of certain tablets, tobacco, like aspirin, we are keeping it, some patients are keeping it between the teeth and the cheeks. Then it can cause chemical burns. So that is chemical injury. And thermal injuries. Thermal injuries can be because of if we are, some hot instrument is there and we are, by mistake, we touch it with the mucosa, then there can be a thermal injury to the gingiva. So in this case, this is in this picture, just this is just for an example, okay? So here you can see that there is injury in the buccal mucosa, okay? This is a chemical injury. So what do you think? If we just do debridement of, if we take a cotton swab and we aggressively debride it, we aggressively debride this region, what will happen? It will not heal, right? We are debriding it. We are, whatever healing that is occurring, and if we'll just rub it, we will be like interfering with the healing that is occurring into this region, okay? So actually, this is a bit tricky question, okay? So in case of gingival trauma, which of these is advised? Aggressive debridement, as it will heal due to good blood supply? No. If we'll do aggressive debridement, there will be no healing only, okay? The second option is no aggressive debridement, as attached gingiva will get necrosed. To this option, we'll come afterwards. This option is definitely not the answer. Now C is aggressive debridement to prevent necrosis. See, if we'll do aggressive debridement, then there are chances that the tissue might get necrosed, right? If we'll continuously do necrosis, say like aggressive debridement, then the tissue might get necrosed. So this option is also not correct. And the fourth option is no aggressive debridement as healing will be affected. So here what I want to say is, if we are continuously debriding it aggressively, okay, if we are continuously irritating the burn, the injury, the trauma with something, it will not heal and finally it will get necrosed. Okay, so the first thing that we have to keep in mind is, if we'll do aggressive debridement, there will be no healing. And if that if that injury is again and again given to the tissue, then it will get necrosed. Okay, so if the answer to this question is no aggressive debridement as healing will be affected. The first thing is healing will be affected. Or if this option was not given in the exams, then the answer would have been no aggressive debridement as attached gingiva may get necrosed. This will be your second choice. Okay, this will be your second choice. If this option was not given in the exam, then this can be the answer. Okay, the first is it will affect the healing. But if in the question they would have given like continuous debridement is done at the traumatic area, then the answer would have been necrosed. Continuous means continuously some form of irritation is given to the traumatized area, then the answer would have been B. But in this case, the answer is D, which is no aggressive debridement and healing will be affected. Okay. Now the fifth question is, which of these is the earliest sign of trauma from occlusion? Here they have asked earliest sign. Okay. So trauma from occlusion, first of all, you should know that trauma from occlusion is of two types. That is primary trauma from occlusion and secondary trauma from occlusion. Okay. So this primary trauma from occlusion is when there is a healthy periodontium. The periodontium is healthy, but the forces which are coming onto the tooth are more than physiologic forces. Okay. In those cases, the trauma which is given to the periodontium is primary trauma from occlusion. And in secondary trauma from occlusion, what happens is the periodontium is compromised, means the patient is already having gingivitis and periodontitis. There is attachment loss, there is bone loss. And in that condition, even when the physiological forces are applied to the tooth, what will happen? The tooth will not be able to bear the forces and there will be more inflammation, there will be more bone loss, there will be pocket formation. Okay, there will be attachment loss. That is called as secondary trauma from occlusion. Just keep in mind this thing. Now, the first thing, so what in the question they have asked is the earliest sign. Now, sign is the first thing that we observe, that which the dentists observe in the patient's mouth, and symptoms are the complaints with which the patient comes to us. Okay, so sign is not something that the patient will tell. It will be something that we'll notice in the patient's mouth, right? So this is a repeat question. This has been repeated many times. This topic is repeated many times. So I don't think anybody would have gone wrong in this question. So let us see the option. The first is tooth wear. Yes, tooth wear is there. Tooth wear is one of the signs of trauma from occlusion. In this picture, you can see that there are wear facets, right? These smooth depressions onto the tooth, which you can see. This is the case of bruxism, because there is attrition of whole of the dentition, lower jaw teeth, and the wear facets can be seen in all of it is completely treated. Wear facets are the depression, smooth shiny surface which can be seen onto the tooth, but these are not the first sign of trauma from occlusion. In trauma from occlusion, what happens is when the forces of occlusion increases, there is PDL widening. PDL widening occurs because of pressure and tension zones that are created onto the tooth. So what happens is when occlusal forces more than the physiologic forces are applied to the periodontium, what will happen? There will be tension and pressure zones created. Thus, there will be widening of the periodontal ligament. And apart from it, in the later stages, there will be bone loss, alveolar crest bone loss, which will be in vertical shape. This we will discuss in detail. This is a very big topic, okay? That we will be discussing in our live sessions and recorded sessions. Don't worry. Just understand that this here in this diagram, you can see that there is pedial widening here. You can see this is the pedial widening. Okay. The tooth will rotate at its fulcrum of rotation, which is at the junction of middle and apical third in the anterior teeth and at the furcation area in the multi-rooted tooth. Okay. So this pedial widening is there. Bone loss here, you can see this angular bone loss has started. This is just to so that the tooth can bear the abnormal occlusal forces which are coming onto the tooth. So this will result in the loss of the periodontium that is surrounding the tooth, and thus there will be increase in the mobility of the tooth. There are different grades of mobility which are given by different classes of mobility, which was given by Miller, and the classes are class 0, 1, 2, 3, and 4. Class 0 is no mobility. Class 1 is mobility that is more than the physiologic mobility. So physiologic mobility is between 10 to 150 micrometers. When the mobility is slightly more than that, it is class 1. Class 2 is mobility in the lateral direction more than 1 mm. But the tooth is not depressible in the socket. Means vertical mobility is still not present. And class 3 is laterally, the tooth can be moved for more than 1 mm, and plus there is vertical depression. The tooth can be depressed vertically in the socket. Okay. So that is the mobility. So mobility is the first sign of trauma from occlusion. This is given in Carranza. This is a repeat question. So mobility is the answer for this question. Other pathologic, other signs which you will see into trauma from occlusion are pathologic migration of the teeth. Okay. So the tooth has a tendency to move away from the occlusal stresses which is coming onto the tooth. It has a tendency to move. Okay. So because of that, there will be pathologic migration. There will be abfraction. Abfraction means because of continuous heavy forces, there will be cracks onto the cervical portion of the tooth, and this crack will finally lead to chipping of the enamel, which will result in depressions onto the cervical portions of the tooth. As you can see here, these are the abfraction fractures onto the enamel, and there will be bone dehiscence. These are the clinical signs of trauma from occlusion. The patient will come with the symptoms of sensitivity because of the recession, because of the abfraction, spacing between the teeth because of the pathologic migration. Okay. And the patient might say that I'm not able to eat properly. The food is getting stuck in between my teeth. These are the symptoms with which the patient will come to you. The answer for this question is mobility. Earliest sign of trauma from occlusion is mobility. Okay. Now, the sixth question is, consider the following points. Marginal gingiva is not affected. Alveolar crest changes are seen. No gingivitis or pocket formation, and it is reversible. So, they have given 4 statements for trauma from occlusion. Which of these points are true for trauma from occlusion? Here, they have not mentioned whether it is a primary trauma from occlusion or secondary trauma from occlusion. If they would have mentioned, okay, it is primary trauma from occlusion, then gingivitis, periodontal pocket formation would have not been there. But here they have not mentioned. So we can say that there might be gingivitis, there might be periodontitis, so there might be pocket formation also. So let us see again the options. Marginal gingiva is not affected. So as we all know, in secondary trauma from occlusion, marginal gingiva can be affected. So this option is not correct. Alveolar crest changes are seen. As we all know, this is true. It is alveolar crest changes are seen in primary trauma occlusion, primary trauma from occlusion also, as well as secondary trauma from occlusion also. The third statement is no gingivitis or pocket formation. As you all know, in secondary trauma from occlusion, there can be gingivitis, there can be pocket formation. So this statement is also not true. And the fourth point is, it is reversible. So it is given in Carranza that there are certain studies which have proved that if we remove the harmful or the excessive occlusal forces onto the tooth, the periodontal conditions, means the widening of the periodontium can be decreased, and also the further loss of the bone can be prevented. The bone which is lost, that cannot be regenerated, but further bone loss can be prevented if the abnormal occlusal forces are removed. So this question, this statement is also true. So the answer to this question will be statement 2 and statement 4 are correct. Okay, for this question. So the answer is D. Now the 7th question is, most common oral lesion in HIV positive patient is. This is also a repeat question and a repeat topic. This also should not be wrong. Okay. So oral lesions in HIV positive patients is seen in about 30 to 70% cases. So 30 to 70 means a large number of HIV positive patients will present with oral lesions. And the most common oral lesion which is there is candidiasis. Just remember that candidiasis is the most common oral lesion which is seen in HIV positive patients, and the most common neoplasm. Most common neoplasm, if it is asked, then it is Kaposi's sarcoma. Kaposi's sarcoma. Okay. This you have to remember. Let us see the other options as well. The patients of HIV will have linear gingival edema. If candidiasis would not have been in the option and they would have given chronic periodontitis or any other thing, then the answer would have been linear gingival edema. The second, this is also there, but to a lesser extent, then is ANUG, that is acute necrotizing ulcerative gingivitis. This condition is also present, and acute necrotizing ulcerative periodontitis is also present in HIV positive patients, but to a lesser extent than candidiasis. So D, if D is given, then D will be the answer. If D is not given, then A will be the answer. Okay. And if neoplasm is asked, then Kaposi's sarcoma will be the answer. Okay. This is a repeat question. This should not be wrong, guys. Okay. Now let us see the 8th question. The 8th question is, in a patient with acute necrotizing ulcerative gingivitis. Acute necrotizing ulcerative gingivitis is ANUG. The ulcers are covered with a whitish membrane, and this whitish membrane is called what? This is also a repeat question, repeat topic, and even in our INICET mock exams, we have asked questions regarding this topic. 2 to 3, I think 3 questions were there, and we have discussed whole of ANUG in our INICET mock exams in detail. So the answer to this question is pseudomembrane. So ANUG presents with punched out crater-like depressions of the interdental papilla as well as the marginal gingiva, which are covered by a pseudomembrane. And this pseudomembrane can be easily removed from the gingiva. And when it is removed, the gingiva which is exposed is shiny, bright red, and hemorrhagic gingiva. Other lesions in which pseudomembrane is, other conditions in which pseudomembrane is present are diphtheria and syphilis. Okay. In diphtheria and syphilis also pseudomembrane is present, but in diphtheria, the pseudomembrane is very difficult to remove, and in syphilis, it cannot be removed. It is undetachable. The pseudomembrane is undetachable. This is also an important MCQ which has been asked previously. So just remember it. The answer to this question is A. Let us see the other options as well. Food debris, this obviously cannot be the answer. So the third option is pyogenic membrane. So what is a pyogenic membrane? It is the membrane which surrounds the pus cavity. That is the pyogenic membrane, and option D is none of this. So the answer to this question is A. Now the 9th question is, which of these is not a secondary colonizer of dental plaque? Just a minute, guys. Okay. Which of these is not a secondary colonizers? Now, there, as we all know, we have studied that suppose this is a tooth surface. So on the tooth, what forms is the pellicle. Okay, pellicle is there. Now this pellicle has certain histidine-rich proteins and proline-rich proteins, certain glycoproteins, which help the bacteria to come and attach to the pellicle surface. This is called as initial colonizers and initial adhesion. And the adhesion of this bacteria is because of certain adhesing molecules which are present on the bacteria which help in attaching to the pellicle. So the bacteria which are coming first onto the and attaching to the dental pellicle are the facultative anaerobic organisms. And these facultative anaerobes are primary colonizers. What they do is they utilize all the oxygen that is present into the environment and thus create a favorable environment for the growth of the secondary colonizers. Now, these secondary colonizers are obligate anaerobes. Okay. So these are obligate anaerobes, means they cannot survive in the presence of oxygen. They need carbon dioxide for their survival. So first the primary colonizers will come. They will attach to the dental plaque. And then there will be secondary colonizers, which will come, attach to the primary colonizers. Now, let us see which organisms are primary colonizers and which are secondary colonizers. So this picture, this grouping was done by Sukransky, and he did a study on 85 individuals. From 85 individuals, he collected approximately 13,000 plaque samples, and he studied those plaque samples. Then he grouped these microorganisms according to the clusters from which they were divided. Means he took a sample, he studied it, and in a particular sample, some cluster of microorganisms were found. So the species which were found together in the same cluster were grouped in the same group, and they were then given color coding. So this color coding, I'll tell you an easy way to remember these color coding. First, let us see which are the primary colonizers. So the primary colonizers here are Streptococcus, the Streptococcus species, and the Actinomyces species. Now, this Actinomyces species was not grouped into a particular cluster because they were found in independently, means they were found in many other classes, with many other clusters also, and as well as independently. So they were not grouped in a single color coding. Says they were not grouped in a single group. They were independent species. Okay. So Streptococcus and Actinomyces species are the primary colonizers. They are facultative anaerobes, and the organisms which are included in primary colonizers are Streptococcus mitis, Oralis sanguis, intermedius, and Actinomyces species. Actinomyces strain A is included in this. Okay. Now, secondary colonizers are, this is the primary, yellow and purple are primary complexes. Now, the secondary colonizers are color-coded green, orange, and red. How you can remember is a traffic signal light. So in traffic signal, as you can see, when there is green light means there is no danger, you can go ahead. Orange means please be aware. There might be some danger, you have to slow down. There might be some danger, just slow down. And red means completely slow down. Don't move forward. It is danger, right? Red is the sign of danger. So accordingly, you have to remember is the organisms which are included in green complex are Echinella species, Capnocytophagus species, and Actinomyces ka strain A is included in green. The microorganisms in green complex are responsible for the periodontal health. Now, orange. Orange complex consists of Campylobacter species, Fusobacterium nucleatum species, and Prevotella species. Okay, so these 3 species are included in orange complex. Now, orange complex are responsible for periodontal pocket formation, and also fusobacterium. In this complex, the fusobacterium acts as a bridging microorganism. Why bridging? Because it acts as a bridge between the primary and the secondary colonizers. It acts as a bridge. It attaches with the primary colonizers also, and it attaches with the secondary colonizers also. So it is a bridging complex. The third is the red. This complex is very important. This is responsible. The microorganisms in this complex are responsible for the periodontal destruction and bleeding on probing. Okay, bleeding on probing. Remember, red blood is red and the complex is red, and the microorganisms which are included in this are also dependent on hemoglobin for their nutrition. The microorganisms consist of Porphyromonas gingivalis, Tannerella forsythus, and Treponema denticola. So these are secondary. This green, orange, and red is the secondary colonizers, and Streptococcus and Actinomyces are the primary colonizers. Now, let us go to the question. Which of these is not a secondary colonizer of dental plaque? The options are Streptococcus sanguis. This is a primary colonizer, as we have already seen. Fusobacterium nucleatum is a member of orange complex, which is a secondary colonizer. Porphyromonas gingivalis is a member of red complex, which is a secondary colonizer. And Tannerella forsythus is a member of red complex, which is a secondary colonizer. So the answer to this question is A, Streptococcus sanguis. Okay. Now let us see the 10th question. Which of these pathogen can be transmitted within the family? Now, pathogen that can be transmitted in the family, they are talking about aggressive periodontitis. Okay. Aggressive periodontitis. And we all know that aggressive periodontitis is divided into localized aggressive periodontitis and generalized aggressive periodontitis. And aggressive periodontitis has a familial transmission. Okay, it's like it has a familial transmission rate. It can be seen. It is like a genetic disorder. It can be seen in the parents as well as in the child. This is one thing that we know about aggressive periodontitis. And the organism that is most commonly associated with aggressive periodontitis is Aggregatibacter actinomycetum comitans. Most commonly, the organism most commonly associated with the localized aggressive periodontitis, the organism which is most commonly associated with localized aggressive periodontitis is AA. And the highest number of organism which is seen in generalized aggressive periodontitis is Porphyromonas gingivalis. Okay, just remember it. But it is not like only these two organisms are associated. It is a polymicrobial infection, but more number of these two organisms are seen in aggressive periodontitis cases. But it is seen in certain studies that Porphyromonas gingivitis cannot be transmitted within the family members, but Aggregatibacter actinomycetum comitans is transferred within the family members. So the answer to this question is A. The answer to this question is A. Okay. This is a table which I have taken from Carranza just to show you what are the different features of aggressive periodontitis and chronic periodontitis. So the rate of progression of aggressive periodontitis is rapid. Chronic periodontitis is slow. There is familial aggregation seen in aggressive periodontitis. It is a familial disorder, but it cannot be seen in chronic periodontitis cases. It may or may not be present. Presence of etiologic factors like plaque and calculus is very minimal in aggressive periodontitis cases, while it is higher in chronic periodontitis cases. Age is mostly aggressive periodontitis patients are less than 35 years of age, and chronic periodontitis patients are an older age group. Clinical inflammation signs are sometimes lacking in aggressive, but signs of inflammation are clearly present in chronic periodontitis cases. Okay. So now the 11th question is, the image shown below is of. So this is an image which was given in the exam. This is also a repeat question. This is a repeat of AIMS. And see, this is a piezoelectric tip. Piezoelectric unit is there. So these are the tips of piezo surgery. These are the tips for piezo surgery. And they can be used for bone cutting. They can be used in implant surgeries. They can be used for sinus lift. They can even be used for scaling and root planing. Okay. So piezoelectric unit can be used in many things. And this tip, particularly with serrations. See, here you can see serrations. These serrations. This is particularly used for cutting the bone. Okay. So here you can see I have given these just for your reference, just to tell you the difference that which tips are used for sinus lift and which tips are used for bone cutting. So these serrated tips, these are used for bone cutting. Okay. Now these are used for preparing the osteotomy sites, and these tips here you can see these tips have like this thing at their end. These tips are used for sinus lift. Okay, but here you can see the tips is serrated. So it is used for bone surgery. So the options, let us see the options. The options are sinus lift instrument, no. Modified osteotomy instrument, no. Titanium insert, it is not a titanium insert. Titanium insert is basically our implants. And piezoelectric bone unit. Piezoelectric bone unit is a unit which is used to cut the bone. It is used for osteotomy. So the answer to this question is D. This is a piezoelectric bone unit. So piezoelectric units work because of certain vibrations, and the vibrations in the piezoelectric unit are linear. They work in a range of 18,000 to 50,000 cycles per second. And why piezoelectric surgery is much better than the regular surgical instruments is because they have a more precision in cutting, means they will cut only the hard tissue, they will not cut the soft tissue. Plus, they'll give more accessibility, more visibility, more clear field because of a process called cavitation. They'll remove all the debris, all the blood particles, and the visual field will be more clearer. Plus, there is less trauma to the hard tissues. Thus, there will be more better healing and the patient will be more comfortable. Even after the procedure, the patient will experience less pain than the normal regular surgeries. So piezo surgeries are much better, but they are a little bit costly. The instruments are a little bit costlier. Okay. Now, let us see the next question. The motion of instrument is in using a piezoelectric ultrasonic scaler. Piezoelectric ultrasonic scaler is used for scaling and root planning. This is also a repeat question, a repeat topic. This is directly picked. These two questions are direct pick. So you should not be wrong in these two questions. Okay. So the ultrasonic scalers have magnetostrictive tips and piezoelectric scalar. Now this piezoelectric works on the tip has a linear motion and magnetostrictive has elliptical motion. Okay. So when we are using a magnetostrictive unit, ultrasonic scalar, the tip will move in elliptical motion and all the sides of the tip will be active when they are working. Means whenever any side of the tip, means the lateral surface, the pointed tip, any side of the unit is touching the tooth, it will has this effect. Means all the sides are working. Here only two sides, 2 points are working. Means it has a linear motion. So only when that particular point is touching the tooth, it will do scaling and root planning, and no other surface will have that effect. These ultrasonic scalars have a work in the range of 18,000 to 50,000 cycles per second. Okay, this is important. You have to remember. They can ask you anytime. Okay, so this is important to remember. So now let us see the options. The motion of instrument in piezoelectric ultrasonic scalar, as we have already seen, is linear. The answer to this question is linear. If it is magnetostrictive, then the answer will be elliptical. Okay. Now let us see the next question, which is identify the suturing technique shown in the image below. So here you have to see that what is done is first the needle is pierced from the buccal flap. So I'll just draw it for you. What is done is this is the flap. Okay. This is the buccal part. This is the lingual part. Now, the needle is pierced from here. The buccal aspect is inserted. It is passed interproximally between the tooth and it is pierced from the buccal aspect of the lingual gingiva. From here, again, it will come out from the lingual aspect of the lingual gingiva. It is taken again from the interproximal area and here a knot is tied. So this is a simple loop suture, means it is pierced from the buccal aspect of the buccal gingiva, taken lingually, interproximal area, then pierced from the buccal aspect of the lingual gingiva and then brought again to from the interproximal area and a knot is tied onto the buccal aspect. This is a simple loop suture. In figure of 8, so this is the answer to this question is B. That is the simple loop suture. But let us have a look at other options as well. The option first is figure of 8 suture. So in figure of 8, what is done is, this is your buccal aspect, this is your lingual aspect, and this is your teeth. Okay. So here, sorry for the bad drawing. So here what we do is we pierce the buccal gingiva, the buccal aspect of the buccal gingiva, take the needle from the interproximal area. Now we do not pierce this lingual as buccal aspect of the lingual gingiva. We turn around and pierce this lingual aspect of the lingual gingiva. Then we move interproximally and tie a knot here. So this is 8. Here you can make out this is a 8. So this is a figure of 8 suture. This is most commonly used in the flap surgeries, but there is one this gives a very tight interproximal contact, but there is one disadvantage. That disadvantage is it interferes with the interdental healing of the tissues because the sutures are in between the tissues. Okay. Now the third is the periosteal suture. So periosteal sutures are usually are used in apically displaced flap. When the flap is displaced apically, we use periosteal sutures. And this is there are two types of periosteal sutures, which are holding sutures. These are the holding sutures. Holding sutures and closing sutures. Okay. So this is the holding suture, means this holds the apically displaced flap at its position, and this is the closing suture. These vertical mattress sutures, you can see these sutures are the holding sutures, which is used to close the flap in the coronal aspect. So these are the periosteal sutures. And then fourth is the sling suture. In sling suture, what is done is, so this is the tooth. Okay. So this is the occlusal aspect of the tooth. And here it is the buccal aspect, and here it is the lingual aspect. This is the buccal aspect, and this is the lingual aspect. So what we'll do, we'll pierce the tissue. We'll pierce the buccal gingiva. We'll not pierce any of the gingiva here. We'll not pierce the lingual gingiva. We'll just take the suture. We'll pass the needle in between the tooth in the interproximal area. Then again, we'll come around here. We'll make a circle around the tooth, and from there we'll pass again from the lingual aspect into the interdental area, pierce the tissue here, Then here again, we'll encircle the tooth, pass from the interdental area and make a knot here. So this is a sling suture. Here we are using the tooth as an anchor, and this is mostly used when only one of the flap is raised. Like when only the buccal flap is raised, we use the sling suture for coronal displacement of the flap. Okay. So the answer to that, the answer to this question is the simple loop suture. This is a simple loop suture. Okay. Now let us see the next question. The next question is, what is the gingival score of a patient who has mild to moderate gingivitis? So this question, I think it is a bit confusing question because they have asked mild to moderate. But mostly it's better if you leave this question because they have asked you the mild also and moderate also. So let us see first what is the gingival index. So gingival index was given, gingival index was given by low and Silness, and the tooth are scored as 0, 1, 2, and 3. In this, 0 is no gingival inflammation is present, 1 is mild gingival inflammation is present, means that there is slight edema and there is no bleeding on probing and slight redness. 2 is there is moderate gingival inflammation present, there is redness is present, bleeding on probing is present, and edema is present. 3 is marked ulceration of the gingiva, and there is like spontaneous bleeding on probing. Okay, like we don't have to probe the gingiva, it will bleed spontaneously. That is grade 3. So what we do is we, with the help of a periodontal probe, we check, suppose this is the tooth. Okay, so this is the tooth. So, and this is the gingiva. What we'll do, we'll insert the probe here and check for the which kind of which score it will come into. We'll insert the probe here. We'll insert one probe in the center. Okay, these 3 regions will be checked, and on the lingual aspect we'll insert the probe. We'll do the total of all these, whatever the score is coming, we'll do the total and divide it with 4 for an individual tooth. But when we are doing it for the whole mouth, what we'll do, whatever score we are getting for the individual tooth and the total number of tooth which we have examined, we'll divide the score of individual tooth, the total score of the individual tooth and the total number of teeth examined So that will give you gingival score of the patient. Now here, the gingival score is from 0.1 to 1 is mild gingivitis. From 1.1 to 2 is moderate gingivitis. And from 2.1 to 3 is severe gingivitis. Okay, here they have asked you mild to moderate. I mean, they might be asking you, like, if a patient is showing some teeth have mild and some teeth have moderate gingivitis, then in those cases, obviously, when we'll do the scoring, mostly it will be towards the moderate gingivitis. So I have given the option answer as, so according to me, the answer to this question is 1.122, that is moderate gingivitis. But somewhat this is a tricky question, and it's better if you leave such questions because they have not mentioned whether mild or only moderate. They cannot tell you mild to moderate. Okay. So let us move to the next question. The next question is, which of these conditions will have maximum amount of leukemic cell infiltration? So leukemic cell infiltration means, here they are asking about the leukemic cell infiltration of the gingiva. So leukemia is the condition in which there is increase in the number of WBCs, and these WBCs are mostly immature WBCs. So when there is increase in the number of WBCs, what they'll do, they'll infiltrate various tissues like the gingiva, liver, spleen, kidney. They'll infiltrate all these organs, and they are called as leukemic cell infiltration. And the most common type of leukemia to cause leukemic cell infiltration is acute monocytic leukemia. That is acute monocytic leukemia. This is a direct pick question. This is given in the Carranza also. means when we'll do a detailed explanation of this these questions, in that I'll give the reference also. This is a direct pick from the Karanza. If you have read this topic, you will know the answer. It is like a medium category question. So the answer to this question is acute monocytic leukemia. Now, the next question is, in a patient, this was the finding. So this image was given. Here you can see this image. This image was given. And what is the diagnosis and the treatment? This exact image was given in the answer in the exam. And this image is taken from an article. And that article, this is the article, Tobacco Pouch Keratosis in Young Individual. This is an article of Journal of Indian Society of Periodontology. Issue is of May and June 2017. This article you can go and read. In that they have given, this is a case which they have published. And in that case, they have given what all treatment they did. So they were expecting the answer according to this article only. So this is a case of tobacco pouch keratosis. So what is tobacco pouch keratosis? In tobacco pouch keratosis, a smokeless tobacco is kept in between the teeth and the mucosa of the patient. And when the because of continuous irritation, what happens is the alveolar mucosa becomes wrinkled, it becomes thickened at there, and there is a depression created, a permanent depression created, which gives the appearance of a pouch. So it is known as tobacco pouch keratosis. This is not a leukoplakia. In leukoplakia, you will not have a pouch-like appearance. Okay, so this is a tobacco pouch keratosis, and most commonly it is seen in the mandibular anterior region, and next the common place is the posterior region. Okay, most commonly it is seen in the mandibular anterior region. Remember, they can ask you next time this question. So in a patient, this was the finding. What is the diagnosis and treatment? So the treatment is, in this article particularly, they did scaling of the patient, gave mouthwash to the patient, asked the patient to quit the habit, and observed and did the follow-up of the patient. So the option that is correct, is the correct answer to this question is, the diagnosis is tobacco pouch keratosis, that is 1, and the treatment is 3, 4, 5, and 6. So the correct answer is A. Okay. Now, just go through this article. Okay, this is very important. Now, the next question is, plaque attaches to the tooth surface with the help of. So the plaque attaches to the tooth surface. Plaque attaches with the help of pellicle, and the bacteria in the plaque produces extracellular polysaccharides and intracellular polysaccharides. This is also a repeat question. Repeat, this topic is repeat. This question is a direct pick from an MCQ book. Okay, just I know all of you have done this question correct only. I'll just explain it to you. So the bacteria in the plaque biofilm produces extracellular polysaccharides and intracellular polysaccharides. The extracellular polysaccharides are, the extracellular polysaccharides are dextrans and levans, which are responsible for the attachment of plaque to the tooth. Plaque biofilm to the tooth. Now, intracellular polysaccharide that is produced is amylopectin, and this amylopectin is metabolized to lactic acid, and this lactic acid is used by other bacteria as a nutritional source. Okay, so the answer to this question is dextran. Now the next question is, supragingival calculus has which of the crystals in maximum amount? Again, a repeat question, a repeat topic. So the calculus can be divided into supragingival and subgingival. Okay, and this calculus has a crystalline structure. There are 4 types of crystals which are present into the calculus. And these 4 crystals are hydroxyapatite, This hydroxyapatite is in the highest amount, that is 58%. This is in the highest amount into the supragingival calculus as well as into the subgingival calculus. The next is the magnesium white locite. This is 21%. Okay. Next is octacalcium phosphate. Calcium phosphate. This is 12%. And the last is brushite, which is 9%. These figures are given in Carranza, and means I know this topic is the most commonly asked topic and you should know it by heart. So hydroxyapatite is in the highest amount in the supragingival and the subgingival calculus. Next is the magnesium white locite. Now the magnesium white locite and hydroxyapatite crystals are present into the subgingival calculus. And hydroxyapatite and octacalcium phosphate are present into the supragingival calculus in the more amount. Brushite is present in the anterior part of the calculus, supragingival calculus, and octacalcium is also present into the posterior part. Okay. So here they have asked you, supragingival calculus has which of the crystals in the maximum amount? As we all know that 58% is hydroxyapatite crystals. So the answer to this question is D, that is hydroxyapatite. Similarly, the next question was subgingival calculus has which of these crystals more in comparison to the supragingival calculus? Now, hydroxyapatite is found in equal amounts in supragingival as well as subgingival calculus. But as we have seen previously, the subgingival calculus has more amount of magnesium white locite. In the subgingival calculus has more amount of magnesium white locite, and supragingival calculus has more amount of octacalcium phosphate. So according to this question, the answer will be magnesium white locite, that is B. Okay. So this is the end of our discussion, and I just hope I was clear and I was able to clear all your doubts. And like if you have any doubts, if you have any feedback, or if you feel that some of the options were like here and there, or some of the questions were like asked in a different way, you can always give us a feedback in the comment section below. And also you can connect with us on our Instagram page, Facebook page, and on our Telegram group. Your suggestions are most welcome, and just I'll wish you all the very best for the results. And also don't worry, this was just the beginning and there is a long road ahead. Just keep working hard. We will be there for you. We will be guiding you at every step, and just keep yourself motivated. Okay, all the best and see you soon. Bye-bye.